didn't mean to do.
That's always.
So we were all well informed.
Well, I had a few little symptoms, and I was in bed, and I think I said it to Andrew. Said I can't get out of bed, so I can't. Go. I know, but I'm fine. I'm fine. So
Okay, good.
I read the minutes, so I know what I missed. It sounded like a good conversation. So hopefully I can chime in today.
Well, great.
Right.
Well, happy to have you.
We
Well,
got
just so you know, we're live on YouTube now.
Thank you. We are. I was able to get Eve on the Google Drive, Kathy, today, so she should be able to upload your comments if she hasn't already.
Okay, super. I think she sent me. I think she is. I think she's got them.
Okay, great.
Okay, we ready to get started? We have Vivian on. We can start now. All right, so I'll kick it off. So due to the COVID-19 pandemic, state of emergency, and Governor Beshear's executive orders regarding social distancing, this meeting is being held via teleconference pursuant to Senate Bill 150 as assigned by the governor on March 30th, 2020, and Attorney General Opinion 20-05, and in accordance with the KRS 61.826, because it is not feasible to offer a primary physical location for the meeting. So thank you. All right. So welcome again, everybody. Everybody's kind of popping on, so we see you coming up. Hello, Rabbi. We got Rabbi Lipkin and now Kathy, everybody. Okay, very good. So everybody have an opportunity to get the minutes as well as the agenda for today. And I see nods. Okay, so just to kind of review that, the agenda will be, of course, we've read the statement, but approval of our minutes from 7/22. Updates, we'll talk a little bit about the, not a lot, just to let you know about the town hall. It went very well. Identify trust building strategies and action steps, and then we want to summarize those action steps and plan for the next meeting, which is not scheduled until August the 19th, unless something unforeseen comes up from today, or of course, we have our town hall on Thursday. So everybody good with this? The agenda, what we're going to talk about today? Okay, excellent. Now at this time, I'll take a motion from the body to accept the minutes as
So
they
moved.
Okay. I don't know. Was that Timothy?
That's Timothy.
Okay, thank you, Timothy. First, is there a second? Okay, Dr. White. Very good. Excellent. So all those in favor, please denote by stating aye.
Aye.
Hi.
Aye.
Nay. Okay, great.
Aye.
Okay, fabulous, fabulous. So the minutes have been properly motioned and accepted. So just to kind of update you all, as I think Andrea had asked about, the first town hall was yesterday. Today is Wednesday. Yes, it was yesterday. And what was that? Racial equity and economics, I believe. I don't know the exact name of the subcommittee, but it went very well. 90 minutes, they used every second of that 90-minute time frame. And I thought that it went beautifully, and it looked like it had about 70 plus people who were viewing. So I thought Renee Shaw did a great job. The panelists did a fabulous job. And again, used the time well and had good distribution and answering, et cetera, with everybody. Our time will be Thursday, tomorrow. Gosh, today is Wednesday. So ours is tomorrow, 6:30 to 8. We encourage all of you to tune in. Now that will be joining myself and Dr. Williams will be Roz Aikens and Dr. Smith, Miss Bibbs, Leslie Bibbs, and then also Lacey, Miss Bryant, and also Michael Halligan. That's correct. Yes, Michael
Halligan.
So thank you. And so that's that'll be tomorrow, 6:30 to 8. Okay, and it's just going to be health disparities. So that will be interesting, having 90 minutes for health disparities. So we're on. So please tune in, critique, and we wish we could have everybody there. I really do. I wish because this work is everybody on this panel today, and of course a few of our team members missing. But just so that you know, yes, Andrea.
I was going to say, I don't know if everyone has received the public notice. Of course, it is on the website, but send it out to your colleagues. Send it out to the people that you engage with, Dr. White, to the folks in the East End that you work with, Stephen, people in West End, like send that out, because I think, Rachel, the group yesterday may have had a little bit of, they didn't get as much feedback and engagement as they really wanted in advance. So they've really pushed the marketing today, but we'd love to get some questions coming into that email in advance to be able to ask the panelists. And yeah, so just, if you know somebody that's been giving you feedback as you've been doing the meetings, send them that email address and ask them to send in a bunch of questions.
Okay.
Good strategy.
Yeah, be careful. No, but that'll be good. Yeah, but it went very well, swimmingly. Any comments or questions on that? And I know some of you had some questions also. And Stephen, I am really having to make sure I'm looking at you, and I'm looking at his picture with the hand up, and I keep wanting to call on you. So forgive me if I inadvertently say, oh, Stephen, what do you need to say? I see Malcolm back there, and I'm thinking, okay, Stephen has questions. So any rate, the other thing I tried to look on, because and Casey's not on here, and some of you had this question about what the Housing and Gentrification Subcommittee is doing. Now, in a nutshell, you all, again, looking at the minutes, just like if people look at our minutes, they're probably not going to glean the full story of all of our robust discussions, et cetera. But some of the things that I just kind of gleaned from this, and this by no means is gospel, but they are in the process of collecting some data from people impacted by redlining and gentrification as part of their committee assessment for their next steps. They're also looking at the impacts of code enforcement that has resulted in people losing their homes and or leading to disinvestment and devaluation of properties, right, in certain areas because of I think that was the implication I was getting from the whole coding enforcement process. They're also wanting to hold rental owners more accountable for safe and affordable housing. And then they're viewing rental and lending disparities in terms of people's ability and access to homes based on process, or structural racism or disability. So those are just very high level, but I couldn't glean from the minutes like any specific directions that they would actually be going in terms of their recommendations to the mayor. Okay, but just so that you all know, I think that they're looking at some things relative to us that would have impact. Hey, Mike. Okay, any other questions there? And so my very capable colleague will be leading us through our discussions today, obviously, as she has always done and done very well. Just remember that scheduled as of today, this is our last meeting. We need to make this impactful. And I believe I would just charge you with, or, a plea to you is to think about what we're asking for. I think a lot of what we've been talking about is where we want to go, what we want to have as an endpoint, but it will be important for Dr. Williams and I, and when we're writing up this report or recommendations, that we also are very specific in our ask, and that we try to think of this along some short-term, intermediate outcomes, maybe long-term, because some of the things we're doing, it's going to take a while. And when we're talking about building the trust in the community, I believe we're going to have to think about some early wins, so to speak. So it would behoove us to also think about this more from a process and time frame. So just keep those things in mind as we think about this and in our thinking and moving ahead. So I just wanted to put that plug in and then hand the baton over to Dr. Williams.
Thank you, Dr. Talbot, for that great setup. You guys have been amazing in the feedback that you've given us. And we've looked at the Google document, and some of you are also adding your recommendations to that document. And that's going to be so helpful to us because Dr. Talbot and I, we really want our recommendations to the mayor to come from all of us, because all of us were invited to share in this process because of the people we work with, the programs that we're overseeing, and the relationships that we've developed with this community over years. So thank you all so very much for just being a part of this with us, because we certainly could not do it without you. So through our conversations over the last few weeks, a lot of times what comes up is lack of trust, lack of trust with the healthcare system. And as we move forward in making the community part of the solutions to what we're experiencing with health inequities, um, there's going to be some lack of trust with the government because some of the processes that we're discussing are new. And when we think about that with the communities that we serve, sometimes that's off-putting to them. So what I'd like to talk about today is just how we can increase trust with the communities that we serve. And Dr. White, especially, with your community engaged research, we particularly want to hear some of the processes that you've developed over the short time that you've been at the University of Kentucky.
So the biggest thing, and this is what I heard from some of my colleagues at the Housing Authority today, is being consistent. And I said this before. So if we're going to do outreach, if we're going to build that trust, it requires us to be out there, whether it's through health screenings. And I know some public health professionals don't like health screenings because they don't feel like they get anything, but community members appreciate that. They remember that. So if it's in conjunction with the health department, and since Dr. Talbert is here with UK healthcare, because the trust there is really lacking, the presence is what's the most important thing.
Okay.
And this is sort of a longer term thing, but I was talking with some colleagues there about, we talked about community health workers, and Vivian's talked about the success of community health workers. So if it's possible to create a partnership with the local community colleges or UK with the mayor's office to actually train residents, give them the skills that they need, and in conjunction with the housing authority, if we're talking about public housing residents, they have a self-sufficiency coordinators there that help out with stuff like that. But their goal is to help residents gain employment, purchase a home if that's one of their goals. So there's a lot of opportunities to train local community health workers that represent the community so that they can be involved too. Because that's going to be, and that's another thing, there's not enough Black people that provide care. And it's a lot easier, and this is for me too, it's a lot easier for me to trust a Black physician or a Black nurse practitioner than it is a white one. Mm-hmm. Just because of the historical racism, and we know about medical experimentation on Black blood and other minoritized groups, but that's really important.
Yeah. So given what we know as scientists and clinicians in the community, we know that there's a shortage of racial ethnic minority scientists and clinicians. So knowing that, it's going to be very challenging to have that concordance. So what characteristics must the person possess to develop that trust, outside of the color of their skin? Because
being present, being consistent. Yeah. So if the health department or the mayor's office decides that they're going to get involved with a certain community, the East End or any other community, it's not just saying, well, this one time only 3 people showed up, so we're not going to do it again.
Gotcha.
It's doing it more than that. But with the shortage, if we had a partnership that included the education systems, then we won't hear people say, oh, there's not enough qualified applicants. Because many times, even without the education system, there are enough qualified applicants. But we know systemic racism exists within our hiring processes. So that would be one way to get them involved, get them the skills so that they can provide for their community, because many of them do want to go into healthcare.
Yeah.
They are in healthcare.
Yes, absolutely. That's a great point, the partnerships.
Yeah, it's very. I just had a question, a point of clarification. So thank you, Dr. White, for that. And I can direct this to you or Ms. Leslie Bibbs to Vivian, because when we talk about community health workers, as I understand it, there's already an established, should I say, job description for that and training, that standard? Because I think one of the things we need to think about, because I think this is a great thing, and I don't think we should leave that. I think because we talked about this earlier on, and I think that if we have a model that's in the community that's working, why not
Yes.
leverage that and target where these individuals are? But also, I think it's important we look at the standardization of their preparation so that the outcomes we link to their presence is giving everybody the same starting point or level playing field to be effective in whatever setting or part of town that they're in. So Vivian, I just wanted to hear more from you on the source of those individuals that, or at least the source of this training, and who kind of drives that.
So we've been working on getting a certification process and getting it approved by the state for about 4 years now. So last year, we got it approved by the State Department for Public Health and Secretary of the Cabinet that Department for Public Health will be the credentialing agency for community health workers. We have core competencies that we've approved, that have gotten approved. We've had recommendations for those that want to be, those entities that want to provide the training. There's an arm that they have to go through, that their curriculum meets the standards and measures that we've set forth. And those that are already trained, if you want to be certified in the state of Kentucky, you have to submit for credentialing through the Department for Public Health. So I think at the last count, I want to say that there were 60 some that have been certified across the state through the Department for Public Health. I'll get that number to you to be exact. And then we have several in the pipeline that are in the process of being credentialed. But you got to remember, COVID stopped a lot of things and slowed a lot of things down. So that wasn't a priority for some. So that's just now beginning to get moving again. So we have several entities that offer training. Fran Feltner with Home Place is one that has, her curriculum has been approved to credential public health, community health workers in the state. There are other entities outside of the state. There's one in Indiana and several others that have applied to Kentucky for being accredited to certify through their curriculum. So there is a mechanism in place, and we did that because for the standardization, of course, but because that they could get reimbursed. A lot of the community health workers were not being paid. And if they were being paid, it was out of a community grant or was out of a short-term pot of money. So now we're working with Medicaid to see if we can get the community health workers paid. And we're talking to our MCOs to see if we can actually, now that we have this entity and this body kind of, here's everybody on that's been met these core competencies and these measures. Now that you have this as a requirement, let's get these folks paid. So that's what we're working on now, and that's still a battle. We're still in conversation with Medicaid, and hopefully they're, by next year, I know we want it now, but hopefully by next year they'll be paid.
Yeah,
through
that's
Medicaid,
great. That's
so.
great progress, though. Thank you. Thank you. Timothy, you had a comment?
Yes, I was going to say, back in our first meeting, I suggested the sort of place-based idea of having something embedded in the community, which gets to sort of a lot of different of these, overcoming some of these barriers. One is access and transportation, but the other is starting to build that trust that we're talking about.
Yes.
So to Brandy's point, consistency of being there in the community, and even if turnout in the beginning is not great, as people see that you're really invested in the community and that you're not going to just go away and that you're there and you're really meant to be a resource for them, that trust will build. And whether it's the community colleges, UK, or other institutions, we also have a lot of nonprofits that do great vocational training. So, to Vivian's point, if folks qualify, having groups like the Urban League or Jubilee Jobs and other nonprofits who specialize in getting people in the pipeline, and if they don't necessarily qualify to actually do the training, partnering with them to make sure that they have the inroads to people, they're trusted entities in the community. So having them as a part of that training pipeline to get people, one, be aware that there's an opportunity. and this opportunity, you know, has legs, and you'll be able to support yourself. And what are the either career ladder or career ladders opportunities by becoming a community health worker and helping to use these sort of community resources in these nonprofits to help usher in folks who are trusted into this pipeline of jobs, which are serving the community. I mean, it's nothing greater than being able to be served by members of your own community. You know that if you live somewhere, if you have to see them when you're going to the grocery store or to church, you know, you build trust with these people because they are invested. They're not just sort of like helicoptering in
Exactly.
all the way to where they live. So I think
Yes.
that really focusing on having some real, truly place-based investments and initiatives will go a long way into starting to build community resiliency. That's really what it's all about.
I'd like to
This
add.
is Mark.
Oh,
I was late and I apologize, but I didn't know if Vivian had mentioned the Promotores program. You probably have covered this before. The Promotores program.
I think she did when she was talking about community health workers, right, Vivian?
I can't hear you, Vivian.
She's on mute.
Vivian, you're muted.
You're on mute.
Okay. So, as I was saying that you couldn't hear, Mark, I didn't mention the Promotores program specifically that Rosa has to help establish, Rosa Martin, years ago, but they're still functioning. We consider them the Latinx version of community health worker. So definitely want to include them, Mark. I didn't mean to exclude them. We were just talking about the African-American community. So,
right. And we did try
correct.
that. We did use that as a guide for the African-American community some years ago, and ours didn't work and wasn't as successful as the Latino group, but they had a 13-week project that was very phenomenal, and it trained people, you know, how to do blood pressures and talk about HIV, diabetes, and the other concerns, health concerns that we have as African-Americans. And also back in the day, we had what was called the African-American Health Network, out of the health department. And that's where all of the organizations that worked with African Americans, was pretty much everybody, would come together to discuss the health concerns for African Americans. And then each year we would work on a disease like diabetes one year, and we'd go out to churches and health fairs and all those places and implement the different things. So for about 6 years, we did all that through the health department.
And Mark, what happened with that program?
The African American Health Network, I moved on, and so the program ended. So I was there.
I was going to say Mark left.
Mark left.
Yeah.
Yeah, and so the program ended, but it was very successful. It was a pilot, and it was only supposed to be 2 years, but it lasted 6 years. And they had a partner program in Louisville, and that too ended.
I have a couple of more things to add, and I think going back to some of the points that have been made, they have to be sustainable positions, long-term, not soft money. And what my recommendations were, Dr. Williams, those are just the beginning steps. So after that, after we've built that trust, I think it's really important that we then start focusing on more structural issues, like making sure that they have easy access. And that brings in a lot of the other groups with transportation and things, making sure that people have access to a provider that they trust and feel comfortable with. Yeah. That's the most important thing, but we have a lot of steps and they are low-hanging fruit. It just takes a lot of energy and time, but it can be done. I mean, it's something that I've done with my students that I work with and the residents and the community that I work with in the housing authority. And it's taken a lot of time, but we're at a place where community members have a voice. We know what the issues are. They're comfortable telling me, I hate UK healthcare. I asked them, what can we do about UK healthcare? It not be UK healthcare. I mean, that's a real problem.
Right.
So there's a lot more steps after that.
Absolutely. And it's exactly what Mark was saying, or Vivian was saying about Mark, and what you're saying. And what I've seen myself as a community engaged researcher, it's a lot of times that trust is built with an individual. And what we'd like to do is really take this broader so that the trust is built with an entity. So the trust is built with the mayor's office. The trust is built with UK healthcare so that it continues, it is sustained. And a big part of that is exactly what you were saying, Dr. Wright, is really workforce development. For keeping people employed and not relying on soft dollars. and funding. And with the community health workers, I wonder how much of the training, Vivian, involves advocacy.
There is a component within the curriculum that specifically addresses advocacy.
That is so important.
It's one of the sections.
Yeah, that's great, because a lot of times what happens is when we think of the community health worker or the promotoras, we consider them to be navigators of care. But they're so much bigger than that. And we know that they can be at the table with their commissioners, with the mayor, being the voice for their community and helping to change policies and procedures.
Mhm.
And
Dr. Williams, I think Kathy's been trying
Kathy,
to talk.
I'm sorry. Kathy, you got to jump in there, girl. Okay, what is it?
I don't know if we were as blue or not. Well, first and foremost, I'd like to say I've learned so much as being a part of this commission committee. If you remember my first session, and I kind of didn't say anything, and my comment was, I need to listen, and that's what I've been doing, and I've been actually diving into what I could find out there, and I did not realize the disparity. It was a lot larger than I thought. I do not think public awareness of this disparity is out there as much as it should be. And so perhaps that folds into this somehow. It just kind of blinded me until I really dove into it. Particularly this morning, I don't know if you all, it's a dated NPR, but not too old. And it was about trust. And it was a study done in Oakland with Black men, and they were assigned the doctor, either Black or white, and they collected data on how the interaction went. And I thought it was amazing. The Black men and the Black doctors, the interaction was more social. They talked about their kids. And then with the white doctors, it was not so much. And then I looked at the disparity, which I know you all know about this, 13%, and we had 5% Black doctors and that people feel comfortable with. So in my mind, it needs to start early. Well, we need more diversity going to med schools. And that needs to be started at an early age so that they feel and they're motivated and they're inspired to enter med school. And then I think in the schools, themselves, the med schools, we need to think about this issue. Again, the public awareness, I do not think it's out there. I was so surprised when I started looking at everything. I also, how many diverse people, how many Black folks or doctors or health clinicians are sitting at tables that are making decisions? I do not know how many are on the health department board. I do not know how many are on the AMA local chapter. And I think that should happen because we need more voices. So I think that we should take a look at pulling that information. What does that landscape look like? And I think that's important. I also do not know the answer to, is there any type of registry of our Black doctors, male and female, in our community? And how does someone access them if they want to feel more comfortable? Because the research shows that it is that way. So there's a lot of different things that I think we need to be looking at. Trust is a long-term relationship. It doesn't happen overnight. But one of the results of that study was that they had 5 different tests you could take with those doctors, and that the participants, there were 600 Black men, they had a white doctor. They took a test that was just really easy to take. The more intrusive or the more complicated test went Black. And so right there, you see the trust factor. So, it has to take a longer term approach. But again, public awareness, I think, is key. And
I'm sorry.
Is key.
Sorry, Kathy. I think a lot of the things that we've been discussing have been tried in the past, but for some reason we do it for 6 years or however long, and then they fall by the wayside. So we're going to have to be sustainable, like everybody's been saying. And the whole thing about having a list We did that a long time ago as well with Dr. Wanda Gonzalez that was here. We had a list of physicians. Some hospitals would not give us the medical providers of color. They just didn't want to do that. You know, so we had a hard time getting that. But Dr. Wanda Gonzalez tried to get a list of African-American medical providers in Fayette County. So it's been tried. It doesn't mean we can't do it again, but hopefully this time things can be different and they'll be more sustainable.
And see, I would not have known that. I would not have known that.
Yeah.
Like you said, it comes in and then it goes away. And
You can get that information from KMA. I can get that too if you want that. I mean,
well, I just was thinking,
you can get that information from KMA, but that's only if they're a member of KMA. And Dr. Gonzalez, Mark, is back in the state when she ran Bluegrass Medical Society.
Right.
You remember it was an organization of just physicians of color. So
Exactly.
she's back in the state working at Kentucky State University. So she might be a good resource if we sustain this group or whatever comes out of this group, she would be a great resource to give you the history of some of what we're talking about in Lexington Fayette.
Right.
nice to know it's been out there. Yeah. Thank you. I'm done.
So I think that's an important point and segue too with our discussions, because we've talked about sustainability. And I think that as we identify some of these things that we want to maybe shape into recommendation for the mayor, I think it would behoove us to talk about what we believe would be important to sustain these efforts for follow-up and also metrics. I keep wanting
Absolutely.
to say, how do we measure our success and what are you all's thoughts on that? Because I think that's really critical. And Wanda Gonzalez is like fabulous. So yeah, if we want to reach out to her, I do on occasion talk to her as well. So
Absolutely. Mike has a point.
Mike Mullis.
Thank you. Thank you, Dr. Williams. So I want to kind of go back to some things that Dr. White talked about, some things that Vivian added in, and all of you have kind of talked on this. And Dr. Talbert, you just said the key word, sustainability. One of the concerns that I have, and Dr. White, you talked about consistency and trust. If a program like this starts in a particular neighborhood, and we're limited in the neighborhoods that we start in because of either capacity or the number of trained individuals, one of the challenges that might be run into is one neighborhood saying, how come we're not included in the plan? How come they've got the plan and we don't have the plan? So I think it's really important to build a holistic plan with a long-term vision. And Mr. Overstreet said this a week ago, and it stuck with me from the moment he said it. You have to build the plan from within. You have to build the plan by community. You have to engage the community in the development of those plans. That's where I think you get the consistency. That's where I think you get the trust. So if it's the Board of Health that oversees the plan, totally making up because I don't know who drives the plan. Having an appointed commission that's neighborhood represented, who understands that one neighborhood might be a starting point, a pilot, another neighborhood might be second or third on the list. The decision criteria might be based on how can we identify African Americans to train as community workers in my community versus a Latino or a Hispanic as a community worker in their community, could dictate the timing.
And maybe the condition of the community, right?
Right. And who's ready for the next step and who's not, as defined by the community. So Dr. White, your point about this is the starting point, there are so many more things that will have to be addressed as we move along. And those things will happen at different pacing in different communities. And if there is a master plan, a master recommendation that starts with some kind of a commission, I'm making that part up because I don't know if that's the answer, where it's about community-based input from the get-go, and it's about community-based input that's sustained, then you don't have a situation like we just talked about before where somebody moves on and a wonderful pilot disappears because the person moved on. It can't be about a person. It's got to be community. It's got to be about the individuals in the community who we engage to change it, right?
Right.
I've been watching pretty closely the debate that's emerged in the last few days about the naming of the basketball arena here in Lexington. And there are some really interesting debates about what's the reality. That's about a community engaging to have discussions as a community and how they learn with one another to get to an ultimate perspective. And I think you've got to have that kind of work in these kinds of situations to be able to successfully sustain it for the long haul. Otherwise, we're going to have a 2-year plan or a 3-year plan or a 6-year plan that as soon as the champion goes away, the plan goes away.
Exactly.
And that's what we have to avoid.
Yeah.
And that's the build it from the community up as communities are ready with all of the criteria, Dr. White, that you just talked about. Here's the criteria you all have to understand when you're ready for the next step as a community, and we have to build it together. And I think is a recommendation that we can make to the mayor. Form a commission, right? I don't think we can make a recommendation to the mayor that says train African-American doctors to be sensitive and make sure that we don't have 5%, make sure we have 25%. Absolutely correct, right? I don't know that the mayor can drive that today. The mayor can set the vision for that need for tomorrow, but I don't know that the mayor can drive that today. What the mayor can drive is let's establish a commission, let's establish a committee of representatives in the community that help us work through the change plan.
Right.
That's what we can drive.
Right. And I agree with you wholeheartedly. And I think that if there is a commission or something that we propose is that it's inclusive, as you mentioned, of everybody or other people in the community, not just the ones who work at a university or at a health department, but get the folks who work at Walmart, the ones that work at Kroger,
absolutely,
places, single moms, single dads, whatever.
Right.
Make sure they're heard. And it's not at 3 o'clock in the afternoon. It's at a time when they can attend.
Right. And Dr. White outlined the core competencies that a community needs to evaluate as they grow, as they expand, as they are successful. And Vivian, you outlined the core competencies of what the training needs to be for a community-based healthcare worker that looks like people in the neighborhood, right? That tells you that you're going in the right direction. And if it's ground up, if it's bottoms up, the sustainability will be more successful. And we can follow Dr. White's plan step by step by step by step and educate people as we go about how to be successful in changing the community and in addressing some of the systemic biases that create all of that in the first place. And frankly, folks, it's what Mr. Overstreet said last week when I was talking about the notion of bringing a mobile pantry into market. At the end of the day, that's a white guy saying, let me go help a Black community. That ain't the right way to do it. It's having the community say, I want this, I need this, I'm committed to making it work. And then it's me and others sharing our experiences and allowing folks to make decisions that help them grow. Right? Having savior white guy syndrome ain't going to get it done. And that's what I am. I'm a savior white guy, right? So I can share experiences, but if I'm just coming in and saying, let me help you, I'm not helping at all because I'm still the white savior walking into a neighborhood that doesn't look like me saying, do it this way. And that's wrong. That doesn't work.
Right. And I think it's important to include our religious leaders. And there may be some on here, I don't know, but it's important that we include them because sometimes, I know the religious institutions are behind health, but I think sometimes they pick and choose when it comes to HIV, they leave off some of the other things that may be uncomfortable. So in that, we have to make sure that our religious institutions are on board and they too educate the community because, we hear often, and I'm sure all of you are aware, we're just going to leave it to the Lord. But the Lord gave you a brain. So we've got to educate our own on how to move forward and advocate for themselves.
I just wanted to chime in on what Mike said. First off, I don't even have to be on the commission anymore. Mike, you got it. You took it over, man. I appreciate everything, bro. But he is exactly right. I just want to reiterate on top of his point, I want to go back to the point that Dr. White made, is that there has to be sustainable money behind it, because the community is going to jump on board when the community knows, okay, it's not just going to go away. If they know that, listen, I got money and this is going to happen over years, and we have an end game and we have a clear plan to get there, and we have the resources to get there, then the community jumps on board. So both of their points put together make an awesome plan.
I want to add one more thing.
I just wanted to.
You want to go first, Vivian? Oh, okay. So I'm a Black woman, and I work with predominantly African-American families. I still don't know just because I'm Black. Number one, because I'm from Chicago. I'm not from here. Number two, I work at UK Healthcare. And number three, I don't live there. So I always come from a place where I'm not the expert. What do I need to support you all to get to where you want to go? And I think that's really important, is recognizing the community experts that are there.
Absolutely.
And not, even as a Black woman,
Right.
I'm not the expert. So I
They
think
are
that's
the expert.
yes. And I think that's really important.
And I think,
I
you know,
just kind of wanted
with
to go
that,
back
with,
to something, Dr. Williams, if I could.
oh, go ahead.
There's a little delay. I don't want to talk over you. On my end, there's a delay. I wanted to go back and touch on something that we started out with, just because I'm old and I don't want to forget it, is when we talked about that training and that pipeline. I was on the call last night. I was on the YouTube channel last night, and they brought up something that I remember that was very successful. And I think this kind of ties in the intersectionality of the different committees. And one of them was putting some additional funding back into a model that worked for years. And that was
The Mayor's Training Center.
the Mayor's Training Center and micro city government. Those were two successful, very successful entities that went away.
Absolutely.
Now, one, had some, other things that were centered around it for, we all know what that was with micro city government, but the model itself was very good. And it was driven by our youth in our community. It was a training ground for leadership for our youth, at least micro city government. And then the Mayor's Training Center was that piece, that tool, that community tool that got people ready to go out and do things within their community or elsewhere. So I think there might be something that we could say to kind of support the work of the other committees when they're talking about that economic piece, when they're talking about what can we put in communities to help them sustain themselves, provide some training, provide some dollars, do something with that leadership and development piece. I don't know. I just wanted to come back to that before I forgot, because I heard that resonate on their call last night. And I think it was, very viable. And Mark, you may remember when that was going on, and Dr. Talbot and others who were here, and Mr. Overstreet, I'm sure you remember when that was put in place. So just something to maybe think about.
Yeah, so what kind of training was provided?
The other group.
What kind of training was provided?
I will chime in on micro city because I'm a huge advocate for it. I think it needs to come back right now, today. Like, let's go out there and get these kids and get them working right now. Well, but I'll tell you what happened. When I was growing up as a kid in West End, I knew for a fact the day I turned 14 years old, I was going to have a job either at the Mayor's Training Center, micro city government, or Parks and Recreation. I knew it. There was no question about it. I knew it. I knew that I was going to have to fill out a job application. I knew that I was going to have a boss. I knew that I was going to have to be at work on time, and I knew that I was going to have to be there for a certain amount of time. It taught me that I needed a job from the very beginning, before I even needed a job. I was 13 and knew next year I'd get a job. And what I did, and also I looked up to the people who had the jobs because they were the people actually interacting with us. So Micro City, I never worked for Micro City. I actually worked for the Mayor's Training Center and Parks and Recreation. I love the pool and the water, so that's what I did. But I went to the park every day as an adolescent growing up to the age of 14. And every day I interacted with those kids that were just in the park getting paid to interact with me. So I got to see influence of kids that were working and earning a paycheck, and they were also interacting with me on a friendship, brotherly level. I met most of my friends in the same park where I ate the free lunch. The free lunch was delivered to the park, and the micro city kids, they handed out the free lunches. So we had nutrition, we had exercise, and we had dollars.
A job.
And a job. And
Wow.
I'll tell you right now, as someone who just pulled their family out of poverty, that the best thing for my health was to get paid.
Yes.
Because once I started to get paid, I could focus more on myself and not on putting food on the table and keeping my lights on. And I'm sorry if I keep going and I'm taking up too much time. But this is something that I'm very passionate about. I do a program for kids in the parks, and it's modeled after Micro City. And if a woman, say a single mother, works for a fast food chain and she makes $10 an hour, and she works a 40-hour-a-week job, she's going to come home with, from her $400, about $320. So in the summertime, say she has a kid that works for the micro city government model, and they make $7.50 an hour, minimum wage. They come home with about $110 per week. So add that $110 per week on top of her $320 per week, you're increasing that family's household income by 33%. In cases of extreme poverty, when you're not making but $19,000 a year and you're adding 33% onto that, everything changes. Everything changes. And it seems like such a small thing to us, but it's such a big thing to those families. And if that single mother has 3 kids, then she's actually doubled her household income for those years and those summers that her kids can work in these programs. And these programs had thousands of kids paid every year by our city government. It's not impossible. It's another example of what Mr. Moses was talking about, where someone goes away and the whole program goes away. And that's not fair to our community, and that's not fair to our children. Thank you for the PSA, Vivian. Appreciate it.
Well said, Mr. Overstreet. Well said.
Very well said.
Y'all got me out here preaching. I didn't want to do that today. I didn't want to do that.
So something that was touched on before, I forget who made the comment. It might have been Mark, but we also need to tie in other sort of community resources like faith-based organizations and institutions of faith. If we're talking about building trust and building authentic relationships, that's what it boils down to. When you start building authentic relationships, that's where trust comes. That's when people know that you see them, they're not so different than you. They have dreams, desires, fears, just like you do. And I think, you know, our churches, our synagogues, our mosques, they're all sort of those institutions that we also need to be partnering with in a meaningful way in order to build that sustainable and consistent relationship within the communities. Not everybody goes to trust, but they're still a trusted focal point within the community.
Absolutely. And Rabbi, you've been pretty quiet today. Something you want to add to that?
Conversation moved too fast for me to jump in at certain points. 2 things I wanted to touch on. Number one, as great as some of these ideas are, and I'm all for a committee suggest another committee to suggest another committee, none of these are immediate. And we still have the to borrow a term from the doctors in the room, we have to do triage before we can decide how to support the patient just to keep it from bleeding out. So something that other communities have done that we could very easily do, for example, is have a mayor's list of healthcare providers that have the seal of approval, whatever you want to call it, who have given some sort of cultural competency training to their healthcare employees. Some sort of training, just a basic level of training, because today there's a patient going to UK emergency room. She's going there today. And we need to change for the future, but tomorrow should be better than today for that patient. And we have the capacity to do that way quicker than we can change the entire system from the ground up, which needs to happen. I don't think that replaces at all the need to form something for the future, but something immediate to make that difference, I think is absolutely critical. And it could be so easily done if we incentivize the organizations to get something that doesn't cost anything, to get on the mayor's list of healthcare organizations that are working towards this, et cetera. And the other thing is, sorry, I lost my train of thought on my second. Come back to me. I'll tell you the second thing I was thinking of.
So I want to build on that first point. I thought we actually talked about that a couple meetings ago, and we're going to pull it out of the previous CHIP study and refresh it and use it. I actually thought that was a recommendation that we already said we were going to do. Did I misunderstand that?
I believe we had discussed the idea. I didn't know that we had put together any official recommendations yet.
Right.
Got it. Understood.
Yes. We're still working on getting more information about the CHIP program. Vivian and Casey Bryan are working on that for us with some of the resources that they have.
Thank you for the clarification. I appreciate that.
Yeah, thank you for reminding us.
The other thing that was on my mind is after a conversation with the incredible Dr. White, I did a little self-study, and I went to Passport's list of approved primary care physicians. And I called a great deal of them, and I asked them, I'm more comfortable having a person of color as my medical provider. And the percentage that could either tell me they had someone or were comfortable allowing me to choose that as who I will see, I think was 2 out of all of them that I called. And I called some 40 odd healthcare providers. The majority of the people I called said, we don't have an African-American healthcare provider on staff. And then several said, we have someone, but we don't allow patients to choose who they're going to see. So even if someone does want that option, when you're calling and saying, I'm on Passport, I'm a new patient, I want to come in, what you get offered isn't always necessarily what you're looking for. Even if you know what you're looking for, and if you're confident enough to speak up and ask what you want, you don't always get offered it.
I'm speechless.
Do I drop a mic or now? What do I do?
You should.
So as we,
sorry, Mr. Overstreet got me in a preaching mood.
Vivian? Vivian, were you?
No, I was saying, I guess I'm not surprised at that, because I think, I've had conversations with several of the folks in this work group that, the cultural competency training we get in the healthcare field and the health professional schools is basically zero. And so I'm not surprised that piece. And I'm also not surprised that we don't have African-American, our pool of African-American medical providers in the city is what it is. I'm not surprised at all. The ones that are trained through our institutions, they leave. We can't keep them in this state. So, and there's a reason for that.
Right.
So, and I think we need to look, take a good hard look of why they leave and why we can't keep, get them to stay. The ones that may stay, they can qualify under the physician shortage areas and get that reimbursement to pay for some of their education, but most of those slots are either in some of our urban areas within specific zip codes and census tracts for shortage areas, but most of them are in Eastern Kentucky. So then there's a cultural piece there that there's a disconnect. So I'm not surprised at all that Rabbi found out what he found out. I think we do need to maybe consider moving forward how to retain some of those folks, create that pipeline for one, get them through and then keep them here in the communities. And because a lot of these folks come right out of Lexington. I can think of 3 right off that were, right from here that are no longer here. So they got trained here, but they didn't stay here. So, it's something about.
I have one comment on cultural competence training. And from what I can tell you, the training that faculty and students receive in my college, it is extremely superficial. And I think a lot of training is like that because we don't allow ourselves to look at our own biases, but that's a whole nother thing with UK healthcare. But something that I've used in the past while I was at the Medical University of South Carolina was the National Coalition Building Institute, NCBI. And it is a phenomenal diversity and inclusivity training. They've done a lot with police departments, with communities, but that could be something that the mayor's office could look at. And it's a training, and it kind of has a train the trainer model. But that's
an excellent idea.
I don't think we should put too much on the cultural competence training that some of our providers are receiving.
Right.
What was the name of that program again, Brandy?
NCBI, National Coalition Building Institute.
Yeah, I was trained in that as well, Brandy, Dr. White, and it was really, really good. And I did that for our social workers across the state that worked in child protection.
So I think one of the benefits of us having this committee
but
is
Dr.
we
White,
could.
you're doing a good job of raising it within your own students. So
I think one of the benefits of this community is we can advise a course if we can find a good one.
Yeah.
We can advise if you want this seal of approval, what that cultural competency training should be. And Vivian, I think the problem that Mr. Moses brought up of good people leaving and the program going with them gets solved if we get good people to stay, which is what you were preaching. The doctors that we train here who start programs here, if we can incentivize them to stay here, then these amazing programs they've started stay here with them. We don't have that problem of someone amazing coming to our community, building something and taking that expertise somewhere else.
All
good
right.
point. Very good.
Absolutely.
And Michael wanted to. Michael?
Yeah, so I've got a question for the medical professionals in the room. How does the licensing process work in order to practice in a given community? Are you licensed by the Board of Health in that community? How does that part of the process work? And I've got a second thought after I understand that a little bit better.
No, we're licensed by the state Board of Licensing.
So would it be feasible, kind of to this point about competency training and the peer-to-peer training and stuff like that, would it be possible for a licensing board to make that a requirement of getting a license, that a doctor commits to that kind of training through a particular type of program? Is that doable?
The nurses, to my understanding, because our director of nursing at the state says it's already required for nurses to get their license now in the state of Kentucky. Now that's what I was told because my office is right next to the director of nursing. So I can double check that. That's required for our nurses that work with the State Department for Public Health.
Oh,
that's part of their requirement. So I
it's
can
a
double check
requirement
to see if that's just with public health
for the job,
or if that's other entities. So, and as far as the medical docs, they're not gonna. There's no, you'd have to incentivize them to do anything like that. They're not going to do it on their own as part of their licensing. I can tell you that now. No.
Okay.
No.
Just where I was going with the whole idea is, if you make it a regulatory requirement,
Right.
would that change the engagement on the cultural training to move the bar? That's where I was going with the idea.
So I'd also like to add that just recently I've been looking at some cultural competency training for my own organization and board. And I met a professor from K-State, Dr. Roger Cleveland, who actually does some of this training, but he hit me.
Raj, yeah.
Oh, okay. He hit me to some other kinds of training that I wasn't familiar with, namely cultural responsiveness and cultural humility, which I'd never heard of before. And it basically goes to sort of Mike's point about changing the mindset that you're not here necessarily to ride in and sort of save the day, but in really sort of engaging with somebody in an authentic sort of way, because oftentimes they have their own way of saving themselves. They just don't have the access and or sort of equitable support. So, you know, just looking at what kinds of training, because I think for so long we've talked just about cultural competency, but it's not the only sort of way of getting to the end goal that we're trying to achieve.
That's right. And some of the best trainers of cultural humility are the people affected by health inequities, such as community health workers and lay people.
Mm-hmm. Right.
So, Dr. Talbert.
4 o'clock, yeah, magical hour. So this has been great conversation. So I think that there are some tangibles, and to Rabbi's point and several of you, for some low hanging fruit and some things that we may want to, as Dr. Williams and I set this up, obviously the document will be coming back to all of you for your approval, but we will probably need to set this up with some things that we can maybe do more immediately to stop the hemorrhaging and the triaging part that Dr. Rabbi Lifkin, now he's going to be a physician, to look at triaging, but also
my mother is so relieved.
To look at some of the staging of this, because I think that it's going to be important for the trust piece that Dr. White and several of you have talked about today, that we have some early wins, and it can't be just this stuff we're promising way in the future. And
exactly.
And then also, I think to Dr. White's point, although this, I don't think well, I know it won't be an official part of the record, I believe that UK Healthcare, for one of the key players in the Lexington footprint, definitely has to get on some things. And we have some things that are in the pipeline, not open for public review at this time. But there are some things that I definitely believe that we have capacity to do for creating more trust, because I think that that's important. And I think I know I was talking to Miss Vivian, and, you know, there are some things for UK healthcare that we inherit just by being UK healthcare that we really don't control or have anything to do with historically, but it is what it is. And we have to embrace and accept that for where we are, but still to appreciate that in how we relate to the community that we're a part of. So I think that all the things that you've talked about are things that we are certainly looking at to leverage, for instance, at Polk Dalton Family Care Center and some other spaces we have that we already have and are embedded in the community, that we can work on those relationships. So I just wanted to say that. And so more to come, right, Dr. Williams, and we'll get this together. The goal is to get something back to you all by the 17th of next month, if not before. And then we'll meet again on the 19th. But I think it's also important just to understand that Vivian, Dr. White, and Michael, and some Timothy, and even, you know, Mark, there are some things we may be calling on you for, because I think that there's some opportunity around the concept that Timothy was talking about in terms of looking at incident and, you know, investment in certain areas, et cetera. And I think that we need to think a little more about what all that entails. I didn't get everything from Dr. White, but we can reach out and get some of those triggers that we should include. That sound reasonable to everybody?
Yes, it does.
Okay. Well, great conversation. Appreciate all of you all. Look at your peers tomorrow, 6:30 to 8. And may the force be with us all as we have the town hall to talk about this. And Stephen, don't call in and give us any hard questions.
I'm done. I'm done. Mike took over my job. I got to talk about micro. I'm done. I'm voting for the mayor again. It's over.
Thank you all.
Thank you. Have a good evening, everyone. Bye-bye.
In a couple of weeks.
Bye.